Hi, I'm Westley Ohman. I'm an assistant professor of vascular surgery at Washington University in St. Louis, and I have the distinct pleasure of discussing carotid, vertebral, and subclavian artery pathologies in patients with vascular Ehlers-Danlos. I have no financial disclosures. All right, so when we are discussing these arteries, I think it's important to have a brief overview of the anatomy, as there are several distinct regions of each of the blood vessels that are important in discussing treatment options. So for the carotid artery, it exists in both the extracranial as well as the intracranial component surrounded by the bony structures of the skull. The vertebral artery has several distinct segments, some which exist within bony structures of the spine and the skull, and some that exist outside, as well as the subclavian artery, which exists deep in the base of the neck, often protected by the clavicle and the first rib. And the area that the arteries provide blood flow to and perfusion to really set the stage for some of the symptoms we'll be talking about later. So for the carotid artery, after it splits into the internal carotid artery and enters the brain, it provides perfusion to areas of the brain that are responsible for motor control or sensation, as well as providing blood flow to the eye, important for visual recognition. The vertebral artery supplies blood to the posterior brain, which is important for coordination, including muscles of the eye, as well as feelings of vertigo or processing information related to vertigo. And then the subclavian artery supplies blood supply to the arm, and so you may recognize ischemic arm pain with subclavian pathology. There are several distinct pathologic features that can happen to each of these blood vessels in patients with vascular Ehlers-Danlos, the most common of which is a dissection or a tearing of the inner lining of the blood vessel away from the outer wall, an aneurysm, which is a dilation with wall weakening of either a focal portion of the wall, so-called saccular aneurysm, or a complete 360 weakening and dilation, and as opposed to a fusiform aneurysm. And then, of course, rupture is one of the most feared complications. And you can see here on the image on the left that there's extensive tortuosity of the blood vessels, particularly of the cerebrovascular system in patients with vascular Ehlers-Danlos. And we think those altered hemodynamics lead to the higher rates of dissection, in addition to the weakening associated with the collagen 1 mutation, or collagen 3A, excuse me. And when we discuss symptoms relating to dissections, it's important to distinguish non-ischemic from ischemic symptoms, as that changes our management moving forward. And so for patients with non-ischemic symptoms related to either a carotid, a vertebral, or a subclavian artery dissection, there's often pain in that region. So if there's an intracranial carotid or vertebral dissection, you may have headache. If it's in the cervical portion, you may have neck pain associated with the dissection. And then carotid dissections can give us what's called Horner syndrome, where there's a disruption in some of the nerve fibers that are adjacent to that artery that run off to the base and neck. And you can see that on this image on the left, that it can be associated with ptosis or a drooping eyelid, a constricted pupil compared to the other side, as well as warm and dry skin due to the lack of sweat production on that side. And that all happens on the ipsilateral side of the dissection. It can be transient or it can be permanent depending upon the extent of irritation and injury to the nerves. You can also have a sensation of your pulse in your ear, or pulsatile tinnitus, and that can be reflected of a carotid dissection in the area of the ear itself as it travels through the base of the skull. You can also have ischemic symptoms, and these are much more concerning from a clinical standpoint. So you can have temporary vision loss. You can have what we call transient ischemic attack, or a more commonly known as a mini stroke, where you have stroke-like symptoms, whether it's a loss of sensation, a loss of motor control, or a loss of vision that persists for less than 24 hours. Or you can have a stroke where those symptoms last longer than 24 hours. And in patients with the subclavian artery dissection, you may have hand or arm numbness or weakness depending upon the extent of the ischemia. So the question becomes, how frequent are these dissections in patients with vascular Ehlers-Danlos? And just earlier this month, the group out of Paris presented the largest experience of what they called supraaortic trunk, or SAT, lesions. And when they retrospectively reviewed imaging, they found that over half of patients ended up having some degree of a supraaortic trunk lesion, but only about 20% of them were symptomatic from an ischemic standpoint, meaning presenting with a TIA or a stroke. And that happened at a mean age of about 33. Out of 144 patients, they identified 184 lesions, and so some patients had multiple lesions, and the vast majority of them were dissections. Over half involved the carotid artery, and roughly a third involved the vertebral artery. And they found that in patients with certain null mutations, that they were much, much more frequent. And just as a comparison, the general population of patients without vascular Ehlers-Danlos for carotid dissections is roughly 1 in 1,000, or 0.1%. And of those, most of them are traumatic in nature. And so this represents a significant disease burden for these patients. Just as a background in terms of the decision or the symptomatic versus asymptomatic nature of these dissections, they found that if the dissection caused complete occlusion of the vessel, that was associated with a significantly higher rate of symptoms. And you can see that of the symptomatic dissections, almost 40% of them were occluded. Here's what they look like on imaging in terms of diagnosis. The vast majority of patients are diagnosed with some sort of axial imaging, whether that's CT scans or MRI, just given the wealth of information as well as the ability to view a lot of these structures within the bony section. Duplex ultrasound is limited. In the case of the vertebral artery, you really get kind of the first segment deep in the neck before it enters the bony structures of the spine. And then it's very, very difficult, if not impossible, to get good high quality imaging the remainder of the way up to the skull base. Same thing with the subclavian artery. You're really limited by some of the bony structures, vis-a-vis the clavicle or the first rib, to really get good visualization. And so CT and MRI have replaced duplex as kind of a first line, as well as a subsequent surveillance imaging modality. When we think of dissections, we typically think of kind of a wispy layer, and I've included these images to show that the vast majority of dissections, at least what we're seeing in St. Louis, involve a narrowing of the lumen without any overt atherosclerotic disease. And so you have to really have a high incidence or index of suspicion, for diagnosis and ultimately management of these conditions. So how do we treat cervical dissections? It's been a large discussion in the neurology literature, and a lot of the information comes from patients without vascular Ehlers-Danlos and have more of the general population, but we do extrapolate the data from that. And so there was a study called the CADIS trial that came out in 2015, looking at full-strength anticoagulation and blood thinning medication versus aspirin therapy alone for 3 months. And what they found was that there was no significant difference between the two groups in terms of aspirin versus anticoagulation. There were no deaths observed in either group. There was one brain bleed observed in the anticoagulation group, but when they went back and reviewed, of the patients that were included, 20% of them with a reported dissection weren't confirmed on the initial review of the imaging. And so we took that and largely swung away from aggressive anticoagulation for patients who had asymptomatic cervical dissections without any ischemic events to the brain. However, earlier this year, there was another study that came out looking at a kind of a non-inferiority complex or a non-inferiority test. And what they found was that while aspirin was not non-inferiority to vitamin K antagonists or anticoagulation, they found that there was a roughly 8% increased relative risk in patients receiving aspirin versus anticoagulation for a stroke. And they saw most of those strokes happen within the first week in the aspirin alone group. And there were roughly equivalent groups of MRI findings between the two. And so these two studies kind of conflict with one not really being able to declare a true winner and one not being able to declare a tie. And so the large question becomes, how do we treat these? And then for patients with high risk, those with ischemic events to the brain, whether a stroke or a TIA, My practice has been moving to aspirin as well as an anticoagulation agent for at least that first month to protect them through what we think is at highest risk first week while the blood vessel remodels and any thrombus that's there stabilizes, whereas those who are low risk from a cervical dissection or high risk from tolerating an anticoagulant are maintained on a high dose aspirin monotherapy. But there's still a large need for identifying what are those high risk imaging features, and then what are the high risk patient characteristics that would suggest they would be better served from a safety profile with aspirin monotherapy. So indications for treatment, invasive angiography is largely reserved for treatment given the high quality images we're able to get from CT scans and MRIs today. The image on the left demonstrates kind of the dissection that you see where there's this hang up of contrast and this wisp within the carotid artery after the injection. And there's a variety of treatments that can be performed for both dissections as well as aneurysms. And an endovascular first management, if we need to do something for patients, has largely been the way the modern experience for vascular Ehlers-Danlos patients has gone, whether that's embolization in terms of plugging up a blood vessel or plugging up an aneurysm versus stent placement in terms of redirecting blood flow around either the dissection or the aneurysm, or trying to avoid open surgery kind of largely as much as possible given the vessel fragility and the higher risk associated with it. There's no well-established size criteria for treatment of these aneurysms in patients with vascular Ehlers-Danlos, and so a lot of it is based on clinical judgment as well as the rate of growth. Here's a patient with a 1 centimeter intracranial vertebral artery aneurysm, and you can imagine in the base of the skull this would be nearly impossible to view with duplex ultrasound. But this is a woman who went from essentially a normal vertebral artery aneurysm or normal vertebral artery to a 1 centimeter aneurysm over an 18-month period, and she was referred here for evaluation and treatment. And in discussion with our neurosurgery colleagues as well as a neurointerventional radiologist, the decision was made to proceed with pipeline embolization. And so you can see on the series of images below, starting on the left, you have the initial angiogram. And then the pipeline stent is an open-celled stent, and what it's designed to do is redirect flow away from the aneurysm to slow the blood flow and eventually induce thrombosis of the aneurysm, rather than have to manipulate the blood vessel itself and that weakened aneurysmal wall. You can stay within a more normal or healthier arterial segment. And she did well after this procedure. And I bring the second patient up because this is a patient who had a stent placed previously for a dissection. He described some ischemic symptoms at the time of the dissection, but he represented as a transfer from another institution with left shoulder, neck, and chest pain that was progressive and worse with any sort of activity. And when we looked back at his imaging, we saw that there was an enlargement of his false lumen at the level of the stent. And so there's still some concern about the interface between the stent and the blood vessel wall in terms of progression of either the original disease or a new disease treatment. And you can see as the blue arrows highlight that the false lumen is roughly the same size, if not larger, than the true lumen. So he underwent embolization of this from an abdominal wall cut down due to no real safe way to access the subclavian artery false lumen, which fortunately did not involve the vertebral artery. And we were able to coil embolize this, and his pain resolved, and he has been stable in subsequent imaging. And so for some of the treatment takeaway from the talk, medical therapy remains the mainstay therapy for dissections, both for those with ischemic symptoms and those without. Endovascular first approach for enlarging or symptomatic aneurysms, as well as continued ischemic issues with dissections, using either coil embolization or stent placement should be considered first, and honestly second and third line therapy, where surgery should be really reserved for patients who have failed endovascular treatment. Rupture is life-threatening and is often treated with sacrifice of the blood vessel if needed, versus covered stent placement and subsequent surveillance of that stent depending upon the location, because some of these blood vessels just cannot safely be embolized unless it's truly a life-threatening emergency. Access site complications in patients with vascular Ehlers-Danlos must be considered in terms of planning how to get to the blood vessel and treatment. And then open surgery should be reserved really as an option of last resort in these patients, just given the friability of the blood vessels and the increased risk associated with that. I want to thank the sponsors for the ability to give this talk today, and I look forward to any questions on the panel. Thank you.